Hello everyone, and welcome to this final presentation in your pre-course material for the ETAT course. Today we're discussing Module 5, Dehydration. As we've said before, the letter D in our ABCCCD stands for dehydration, and this is one of the emergency signs. At the end of this module, you should be able to assess for severe dehydration, know how to give fluids for severe dehydration, and understand how to rehydrate a child with severe dehydration who also has other conditions such as severe acute malnutrition or heart failure, etc. The first question we need to ask ourselves is, does the child have a risk for dehydration? In other words, do they have a history of diarrhea, a history of vomiting, or a history of poor feeding? If the answer is no, then we can move on to our priority signs, because this is the last of the emergency signs, and all the previous ones should have been negative if we've got to this stage. If the answer is yes, then we need to move on to assess for severe dehydration. To do this, we need again to ask ourselves 4 questions, and 2 of these need to be positive. So, is the child lethargic? In other words, responding to a V on the AVPU score. Is he or she drinking poorly or not at all? Does he or she have sunken eyes? And does the skin pinch go back slowly, longer than 2 seconds? Table 7 in your manual gives us an overview of the assessment and management of dehydration. If 2 of the signs are positive, we take the child to the resuscitation area, as this is counted as an emergency. We then provide the management that is in the right-hand column. We'll go more into detail on these aspects in the coming slides. So, just to understand the questions that we're asking ourselves, is he or she drinking poorly? A child who has some dehydration will be thirsty and drink eagerly, where a child with severe dehydration will be too sleepy or lethargic to drink adequate amounts, or unable to drink at all. We'll see some of these signs in the videos in a few minutes. Is he or she lethargic? In other words, does the child appear drowsy, doesn't show interest to what is happening around him, just staring blankly, and may even not even respond to his or her name or answer questions sensibly. If you look at the child on the right, you can see she appears to just be staring blankly. Does he or she have sunken eyes? Look at the child's eyes and see if they appear to be unusually sunken into the socket. Some children have deep-set eyes, and therefore it might be rather a genetic predisposition to having deep eyes or sunken eyes rather than dehydration. The best way to assess whether this is the case is to compare the child's eyes with the mother's eyes. If both are deep sunken, then it is less likely to be dehydration. In the same way, the person who would know best whether the child's eyes were sunken would be the mother. So ask the mother what she thinks of the child's eyes, or if the caregiver is the father, then they could also be asked. The next sign is, does the skin pinch go back very slowly? So it's important how we do the skin pinch. So you need to locate the area on the child's abdomen halfway between the umbilicus and the side of the abdomen. Pinch the skin in a vertical direction, in other words from head to foot, and not across. Pick up all layers of the skin and the tissue underneath. Pinch it for 1 second and then release. See if it goes back slowly. This picture is figure 27 in your manual. We will also see a video that shows how to do this. Let's go to the videos. This is a very dark video, but we can see that this child's eyes, best looked at from the side, do appear to be sunken. This child not only has sunken eyes, but also appears to be very lethargic. This child does look like she has sunken eyes, but this may be genetic. So here I would definitely compare to the mother to see if her eyes might be similar. It would be the best way to assess this child. You'll see the skin pinch goes back quite slowly, but you'll notice this is quite lateral. We had advised that the best place would be between the umbilicus and the side. This is a better position, and if you look, the skin pinch seems to go back almost completely. I would not call this a slow skin pinch. In other words, this is not a sign of severe dehydration. This child appears malnourished because there's a lot of loose skin, but in addition, the skin pinch goes back very slowly. You can see it's definitely more than 2 seconds. There are a few general principles that we need to follow when we're looking at dehydration management. The first is to treat fluid like a drug. So in other words, we need to make sure that we give it safely. So we do the least harm if we give fluid orally. And if this is not tolerated or is not possible, then we would give it via an NG tube. If this is not tolerated or not possible, then we would give it intravenously, or if we're unable to get a line, then via an intraosseous line. At the same time, the child needs constant reassessment. We want to make sure that we're not either giving the child too little fluid and they go back into shock, or that we're giving the child too much fluid and they become fluid overloaded. Shock we've discussed in our previous module, and fluid overload can be seen by several signs. They might become more tachypneic, they might become more tachycardic, or the liver might increase in size. One of the recommendations that we make is that you mark the size of the liver on the child's abdomen before starting IV fluid, and monitor that when doing the reassessment every 2 hours. Every 4 hours we need to reassess for the hydration status to see if the child is improving or getting worse. In these patients, we need to be cautious with our intravenous replacement. So in other words, we need to try and avoid it at all costs, and if we do need to do it, we need to make sure we are definitely reassessing frequently. So children with severe febrile illness, pneumonia, severe malaria, meningitis, severe acute malnutrition, severe anemia, congestive heart failure with pulmonary edema, congenital heart disease, renal failure, and diabetic ketoacidosis. All of these children are prone to fluid overload, either because they're already fluid overloaded, such as the ones on the right-hand side, or because their hearts or their myocardium may be under strain and therefore will not be able to tolerate increase or excess IV fluid. Dehydration management has sometimes been found to be quite tricky, but if one follows an algorithm, it is actually quite easy to understand. On chart 8, you will find the algorithm, and we will go through it in more detail now. Let's look into this algorithm in more detail. In a child who presents with diarrhea or vomiting or poor feeding, we can classify them into 4 groups. child with no visible dehydration, a child with shock, a child with severe dehydration but no shock, or a child with some dehydration. To come to this diagnosis, we look at the boxes above. If a child has all of the following, they are well or alert on the AVPU scale, their eyes are not sunken, their skin pinch is normal, and they're drinking normally, then we would say they have no visible dehydration. We've already discussed the criteria for shock, but just as a reminder, they need to have all three of the following: cold hands, capillary refill time more than 3 seconds, and a weak and fast pulse. The two that are often difficult to distinguish are some dehydration and severe dehydration. The main difference between these two is whether we treat the children as an emergency or whether we treat them as a priority. If they have two of the following, they're lethargic, they have sunken eyes, they have a very slow skin pinch more than 2 seconds, or if they're drinking poorly or not at all, then they're classified as severe dehydration, but with no shock. If they have two of the following, restless or irritable, sunken eyes, skin pinch is slow but less than 2 seconds, or they're thirsty or eager to drink, then they have some dehydration. The child with severe dehydration we would treat as an emergency. The child with some dehydration, because they're restless or irritable, they would be considered a priority, taken to the front of the queue, and fluid management started there. If we move on now to our initial management of the children, for those who have no visible dehydration, we would give oral rehydration solution 10 ml per kilogram after every loose stool or when they are thirsty. These children could probably be discharged home with warning to the mother of what danger signs would be, unless they had other reasons for admission. A child in shock, we've already described the initial management. We would assess them for severe acute malnutrition, and then we would give them fluid management to treat the shock. Once their shock had improved, then we would need to continue giving fluid management. Because they had been shocked, we would want to give this intravenously. So we would give half DD, 10 ml per kilogram per hour for 4 hours. Plus, we would give oral rehydration 5 ml per kg every hour if they were able to drink. And if they were able to feed, we would give them oral feeds. Because they're on IV fluid, we need to reassess them every 2 hours for shock or fluid overload, as previously described. If we were to find that they were shocked or fluid overloaded, we would move to this red section in the middle. If they were shocked, we would again treat for shock according to our previous module, and we would call the senior. If they were fluid overload, just as a reminder, if they become tachypneic, tachycardic, or their liver increases in size, then we would stop the fluid replacement and we would change to maintenance fluid and call a senior. If we did not find them shocked or fluid overloaded, we would continue with the fluid replacement and we would reassess them after 4 hours for their hydration status. If they were worse or not getting better, then we would have to increase the intravenous rate by about 25%. This is a quarter of the rate that we're currently giving. If we found that they were better, but they still were dehydrated, then we would continue with the same rate of fluid. If they now had no dehydration, then we would decrease the intravenous rate by 50%. And if they were coping on this and we were down to 5 ml per kg per hour, then we could stop the IV fluid. Again, in all these patients, we need to reassess them every 2 hours for shock or fluid overload and reassess them every 4 hours for their hydration status. If we now look again at the children who have severe dehydration with no shock or some dehydration, the management is the same except the classification of emergency versus priority. For fluid management, we would attempt to initially give them oral fluid. So we would give them oral rehydration solution, 5 ml per kilogram every 15 minutes via the mouth, or if they were not able to take it orally, then we would do it via an NG tube, and we would either give it every 5 ml every 15 minutes, or this is the same as 20 ml per kg every hour. If they were able to take feeds, we would give them feeds as well. We would again reassess these children every 2 hours for shock or fluid overload, and if we found that to be the case, then we would follow this red section in the middle, as we did with the previous patients. If we reassess the child every 4 hours for their hydration status, we could find that they are either worse or not tolerating the oral or nasogastric fluid. In this case, we would change to IV fluid, which would be the same rate that we gave to the child who had been in shock, and we would reassess them every 2 hours for shock or fluid overload. If the child was doing better, then we would continue with the same oral or nasogastric fluid. If they had improved to the state where they had no dehydration, then we would be able to stop that oral fluid every 15 minutes and change them to 10 ml per kg after every loose stool or when they're thirsty. That is the same as the child who presented with no visible dehydration to start with. The second part of this chart shows what volumes of fluid we give to each of these patients. You've got the weight on the left-hand side and the volume of fluid that we would give every 15 minutes. So in other words, if the child weighed less than 4, you would give them 15 ml every 15 minutes. This is the equivalent of 60 ml every hour. Table 9 speaks to what IV fluids we give if oral fluids are not tolerated or the child was previously shocked. The fluid volume that we give is half DD 10 ml per kilogram per hour for 4 hours. Again, the volumes are calculated according to the weight. And there's a reminder here to reassess the child every 2 hours for shock and fluid overload and every 4 hours to assess the hydration status. If the hydration status is not improving, increase the fluid rate by 25%. Also give ORS solution as soon as the child can drink. For those children that had been on IV fluids but are now able to drink, we would want to start introducing oral rehydration solution. We would start this at 5 ml every hour, and we would increase according to how the child was tolerating it. There is an error in this table. This is the amount that should be given every hour to start with. However, we can increase it to the equivalent of 5 ml every 15 minutes, which would be what the total on this side would be. So in summary, we would do the following. Treat shock if it is present. Once the shock was corrected, we would continue with intravenous or intraosseous fluids. If there had been severe or some dehydration but no shock, we would want to start with oral fluids. If the child is not drinking spontaneously, then we could place a nasogastric tube and give nasogastric fluids. If oral fluids or nasogastric fluids were not tolerated, then we would give IV or IO fluids. In all cases, we would reassess the child in 2 hours for shock or fluid overload and reassess in 4 hours for their hydration status. This would tell us whether we should increase or decrease the fluid. Once the child with severe dehydration is rehydrated, we would reduce the IV fluids and increase oral fluids. Check and treat glucose, especially in children with severe malnutrition, and introduce oral feeds as soon as the child is able to tolerate them. The assessment questions are on page 57. Thank you very much.